Good morning.
Good morning.
Good morning.
It is such a privilege for me to introduce a special guest that we've got on our campus today. And we're on our campus a lot, but this is a special day. My name is Frank Degree, and I chair the Department of Family Medicine. And we host distinguished speakers to our campus from time to time to give lectures and lead discussions that otherwise make us better than we are. And boy, are we going to get a dose of that today. Dayna Matthew is our distinguished speaker today, and the first thing that we're going to do this morning, we have a jointly sponsored discussion that is sponsored by the Levitt Lectureship, but also by the Anschutz Inclusivity Alliance, represented today by Dr. Sean McMahon and Kate Huckabee, who will actually facilitate the discussion. What we're going to do for the next hour and a half is turn Dayna Matthew loose on her. I want to tell you a little bit about her, and then I'm going to give her the podium, and then Sean and Kate will facilitate a discussion. Dayna is a professor of law at the University of Colorado School of Law. She's also a professor in the School of Public Health here on this campus. And with a tailwind and some good luck, she'll probably be a professor of a bunch of other things around here as well. She's not only a distinguished and rigorous legal professor, faculty, but she's also an activist. And she knows how to do things that make the world better. Among the things that she has done is work as a special advisor to the director of the Office of Civil Rights for the EPA in Washington. She's most recently she's come back to us just now from a stint as a health policy fellow of the Robert Wood Johnson Foundation, which she did that's a one-year gig, but she did it for 2, didn't you?
I did it for 1 year.
Okay, so she did that. And she's also worked in the school as a vice dean for a year. I take it that was putting your thumb in the dike so the place would not come unraveled. That looks like a service commitment if I ever saw one. And she works on the Center for Bioethics and Humanities on this campus also. She's been a co-founder of the Colorado Health Equity Project, a medical legal partnership whose mission is to remove barriers to good health for low-income clients. And she's been a practicing attorney. She's done that in Kentucky and Virginia. If she wants to tell you more about that, she can. I'm going to skim that. But the accomplishment that I want to tell you about carefully, that I want to slow down and take a breath and make sure you hear me, is that she's recently written a book that is brilliant. Read it. She's going to talk about some of the issues, the elements of that. It's called Just Medicine, a Cure for Racial Inequality in American Healthcare. She does policy work as a lawyer, and she does a lot of health policy work. She knows a lot about this. And she's published a book that can advance our understanding and can inspire us to action in order to do something about the problem and the ubiquitous problem of racial inequality and of bias in healthcare that she's going to talk about a little bit for the next hour or less, after which she'll sign your copy of the book if you like, because we've got some. If Shauna or Kate wish to add anything to this, you can. If not, I'll give the podium to Dayna Matthew. Join me in welcoming her. Here we go.
I find it hard to put into words what a privilege it is to be standing with you.
I left campus 2.5 years ago to go figure out how to do health policy, and lots of what I learned was that this is the audience that change will actually come from. So to come back and to have Frank and this school invite me to speak as soon as I return is a huge honor, and I'm very grateful. And now I'm going to be very disruptive. That was me being polite. All right, I think the way that we might proceed here is that I might talk for maybe 5 minutes or so, and then a conversation should follow, and I would very much like to respond to the things that are most interesting to you about the topic of the book. But I'll set it up just by answering one of the questions that the Alliance for Inclusivity sent to me, which I don't know how long you've been in existence, but bravo, that was not around when I left. So this is a changed campus, and I'm going to follow my sense and instinct that it is a campus ready to be disrupted and ready to be disruptive with me. And so let's see if that instinct is true. I'll start with a story. One of the things that I did in college was I ran as a sprinter. Well, those days are over. So I've tried to make myself into a long-distance runner. While I was in D.C., I was training with the U.S. Marines, believe it or not. And what would happen is every Saturday morning, we would get up and meet at the U.S. Marine Corps Memorial in Arlington, Virginia. That was, give or take 60 seconds, 5 minutes from my house where I lived while I was in D.C. Important because the story I want to tell you was about a day I was going to do a really long run for me. I was a sprinter, now I'm going to run 18 miles. Really long run, so I'm nervous, and I'm very, very focused. I call Lyft, put in the destination in Arlington, 5 minutes from my house, and I go get some fuel, right? Which is what runners call a banana, basically. So I go to the Giant to grab my banana, and I run behind the Lyft car when it arrives, open it up, sit down, and the Lyft driver turns around and looks at me and says, "Oh," pause. "You're going to Virginia? I've been driving all night. I don't want to go there. You'll have to call someone else." So, again, I was focused, so I didn't really pay any attention. I just had sort of my East Coast arrogance on, and I said, "Oh, but you're going to go to Virginia. It's 5 minutes away, and then you'll rest, because I've got to do what I've got to do." And he looks at me and he goes, "I want you to get out of my cab." And I said, "Oh, that's what's going on, huh?" Because now my antennae are up and I'm perceiving things out of my own biases, right? And I said, no, actually I'm not going to get out of your cab. You're going to take me where it says I input before you took this ride. He canceled the ride with me in the car, locked the door, and started driving away. So now I'm not arrogant, I'm petrified, right? And I'm thinking, I definitely played this wrong. I'm about to be kidnapped here. So I bang on the door, and understand, this happened 2 months ago. This is not something that happened in 1960, right? I bang on the door, and I say, "Let me out of your car right now." He stopped, he turned around, and he looked at me, and he said, "Do you want to go home with me?" And I said, "No, let me out now." I got out of the car trembling, literally trembling. I wanted to dial something. So I do the most irrational thing I think I've done since I was 10. I walk around his car and I open every door. I don't know. It was the only aggressive thing I could think of that. So the end of the story goes like this, and here's the real gravamen. That was a Saturday, did my run, did okay, went great. I'm grumpy all day Saturday. I attribute it to the run. Sunday, I'm grumpy all day Sunday, and I can't figure out why. Monday, I've got an 8 o'clock meeting. I get into another cab. It was a Lyft cab. I called Lyft again, and I said, "Is there someplace I can report a driver who I think has been inappropriate?" gave me the emergency number. I call the emergency number, and they answer like this. This is Lyft. What is your emergency? I say, verbatim, I think I was discriminated against for my race, but I'm not sure, and it was Saturday. So the guy on the other end of the phone has a Southern accent. I'm pretty clear he's not going to listen to me, but I don't know what else to say. Why am I clear? Because of my biases, right? When I hear a guy with a Southern accent, I think he doesn't want to hear about my non-emergent racial suspicion that I can't validate, right? His answer to me was this. That is an emergency, man. That should never have happened to you. If you want to stay on this phone all day, I will talk to you about what happened to you. Tell me all about it. At that moment, I'm not going to tell you exactly how old I am, but I'm old enough not to have had this happen. I just started crying. I literally started crying. And what I want to reflect to you was that experience I experienced physically, right? My body held on to the pain of the feeling that I might have been discriminated against, right? Because this driver didn't use the N-word. He didn't tell me I don't want to drive you because you are a black woman out of my cab, get out of my cab. He just reacted to me in a way that I experienced as racial bias, based on my past associations, based on what I have stored in my amygdala of other similar experiences. That's how I took it, and my body actually tensed for 3 days. My emotions were off. I dare say that if somebody had taken some kind of biomedical measures, you would have found hormones out of order. You would have found things that were directly and physically responsive. That's what this book suggests we have to address, right? I wrote it because the problem of health disparities is pervasive and pernicious, and we're not moving the needle fast enough. By one estimate, 84,000 people die a year due to health disparities. That's an estimate by Louis Satcher, the 16th Surgeon General of the United States. That's too many deaths. It's too costly. And so my surmise is that there's something we're not talking about. We're throwing money at it. The ACA, God love it if it lasts, was throwing all kinds of research at it, and still we're not moving the needle. My surmise is that we're not talking about racism. It's too hard a conversation. We're not clear about its import or impact. And so I wrote that book to start that conversation. So the last thing I will say is that it is important to distinguish between implicit and explicit racism. Back to the Liv story. If the driver had said to me, I don't like the way you look, or called me some sort of a word that would have signaled his bigotry and his prejudice, then I would have known what to do right away, because I'm familiar with that scenario. Instead, his and my biases interacted with one another. To this moment, I don't know truly why he put me out of his car. That's not true. I know why he put me out of his car. To this moment, I don't know exactly what to do about that, right? But this book is about the conversation surrounding implicit, unconscious racism, which is different from explicit, intentional racism that affects healthcare. Because I think that is one of the biggest contributors to health disparities that we are not dealing with. So that's what I'd like to talk about. Where do I go now?
This is a large group for discussion, but I definitely think that we would probably enjoy sort of hearing people respond. One, I hate microphones, so I'm going to yell. If you prefer a microphone move around for responding to the questions that Kate and I are about to pose to you, we can have one. But I think that this is we're okay, probably, to shout. Usually when I I started a discussion about a book of this nature, I just really want to know what struck you. And since there is a large number of us here, obviously we aren't all going to be able to share this, but we are open to the idea of splitting into smaller groups if that's something that we'd like to do. But we can start with, anyone want to share? And we're lucky enough to have our author here with us so that we can get an interesting dialogue going.
So what struck me is the not knowing what to do. I can say I've had similar experiences, but then you just don't know what you're supposed to do in that moment. For Lyft, at least you have a number to call. Sometimes it's a doctor's office. I interact with the medical spaces in that kind of position. And I've had an array of experiences, but sometimes you're like, who exactly do I call in a way that it won't be detrimental to my care? It's kind of
And you're speaking from the patient's perspective.
from the patient's perspective, where it's like, I'm a very well-educated woman, and I struggle sometimes on being heard. And I've moved around a lot, so, having to learn how to advocate for yourself, how to establish care. And so it's always interesting because it's like, what do you do when it's wrong? And you're so emotionally charged and frustrated that you just don't know where to turn exactly. And that's the part that can be really difficult.
Sure. I think there is incumbent upon the healthcare system, healthcare providers and clinicians to do what we know to do. And what we know to do, before I answer from a patient's perspective, what we know to do is actually fairly sophisticated and extensive. There is a lot of literature, I hope we get to some of it in this discussion, about what kinds of things will de-bias us, right? But let me speak directly to the patient's perspective. The first thing I would say is not unique to patients, but all of us should assume we have biases. We should assume that we not only have biases, but that we have racial and ethnic biases, right? We should assume it without the fear of being labeled, either internally or externally, as a quote-unquote racist, right? It is very, very important that we demystify and demonize, if that's a word, right? The notion that the way we operate in this world is by having biases, right? So you as a patient should assume I have biases and the provider that I am interacting with has biases as well, right? What does that mean? That means that I will work preventatively to accommodate them, meaning to understand how they operate, how they might express themselves, and what I might do when I get the sense that the biases are at play, right? So I will go in with a plan, like, all right, Weight Watchers, right? The way you are able to resist the hors d'oeuvres tray is to have a plan ahead of time before you go to the party, right? Similarly, when you go to see a provider, whether it's a physician, a dentist, or whatever, you should have a plan before you go in because you've assumed and understood how biases work. So how do they work? They work with a fair amount of automaticity. That's the psychologist word for it, right? And that means that your biases, stereotypes, are called up and triggered automatically, unintentionally, without you even intending that. Moreover, importantly, your biases will betray your explicit preferences, right? So you don't have to think of the provider who is treating you in a way that really does feel like prejudice and discrimination. You don't have to assume they're a frank bigot, right? They're not necessarily, I'm not saying they're not, but they're very unlikely to be a bigot. Most health providers don't go into the office each morning thinking, how am I going to discriminate against the people that I'm going to care for? That's not what's going on. Because of that, your preparation as a patient doesn't have to be hostile, but it can be wise. It can be informed, right? So you're prepared. You, secondly, know how biases operate automatically. Thirdly, you should understand how they appear or express themselves in the clinical encounter. Some of the evidence tells us that your provider will use body language to distance him or herself from you, sit further from you, not be tactile, not make eye contact, perhaps even be verbally dominant, not eliciting information from you in conversation. right? You will see research that tells us, having coded interactions clinically between dyads of patients who are not similarly situated racially, black, white, and so forth, that these kinds of things are evidence of bias, right? You will therefore take responsibility, ownership, and management of your clinical encounter to reverse those patterns. You'll slow the conversation down. You'll interrupt and ask questions. You will take ownership of your own care in a way that you might not have had you not anticipated that the bias was going to express itself that way, right? You'll ask more questions. You'll have more of an interaction. You'll ask for more information. Because indeed we know that implicit racial biases cause providers, good people, who are egalitarian and progressive in their explicit preferences, to limit the amount of information, to limit the clinical options that they provide to people who are racially unlike themselves, right? So that's the last thing. You'll be prepared, perhaps without some cynicism. It's hard not to have a little bit, right? But you'll be prepared to ask questions framed a little differently, but is that what you would recommend to other patients as well? That's the underlying question, right? Because what we know about implicit bias is that it is a habit, it can be reversed, even though it is unintentional, intentional interventions at the individual level can change them, and you will, as a patient, then be giving your provider time to pause, to reflect, and perhaps to override what they don't intend to be communicating with you.
So my own thing is, I think that was very helpful, because that's the approach I take. But the challenge is draining. So I'm going to step back and take it from the patient's perspective, that it tends to be in a more vulnerable position. And if you're interacting with the medical system on a regular basis, that's exhausting in itself, in terms of like outcomes and things of that nature. So my thing is, you have to take that approach, which is something as a patient, as a public health practitioner, that's what I want to engage with patients. That's the kind of coaching I would give. But the challenge is it's draining, because sometimes it's not a one-time thing. So if you're going to stay with that specific provider, you're dealing with that on an ongoing basis. So how does that affect you and your health outcomes?
So, two things I would respond. One, I would hope that the evidence that providers, for example, are here to have that conversation means that we're coming at the problem from two different ends, right? So that perhaps you found an enlightened provider who, though biased and though it's a difficult space, is also working on their biases, right? If I can be just a little bit wonky for one moment, and then I'll get to the second part about it just being exhausting. I am with you. There is a study done by Alexander Green. It was published in 2009-ish, all right? And it was a really important study about coronary artery disease patients and their likelihood to receive thrombolysis, which for the participants in the experiment was the treatment of choice, all right? So without telling you a lot about the experiment, the primary care physicians were asked to see these actors and actresses who were only different by race and gender on a video, and they heard a vignette. They got the same clinical data for each of the actors posing as patients, and then they were asked to make a recommendation. The physicians were also asked to take a survey so that their explicit racial preferences could be revealed, and they were asked to take the implicit association test so that their implicit racial and ethnic biases could be measured. All of this was combined or cross-tabulated. As you might expect, and if you want to talk more about that experiment, I will be glad to do it, but as you might expect, there was an inverse relationship between the level of implicit bias as it went up, pro-white, anti-black, and the likelihood that minority patients would get thrombolysis, the treatment of choice, right? So the more biased these physicians were implicitly, the less likely they were to give the treatment of choice to black patients. And the reverse was true. The less biased they were, the more likely they were to give the treatment of choice to black patients, right? So we have a correlation. Here's why I tell the story now in response to your question. There was a small subset of the physicians who were told what the experiment was about. They weren't duped, in other words. They knew this was about patients, race, and the quality of care. That group of physicians exhibited the reverse pattern for treatment, right? So I'm hoping that because there are people like those in this room, that we are working at this from two ends, not just the patient end, and that knowing about the problem and looking at other debiasing solutions, of which there are many debiasing solutions, right? The providers will also be changing at the same time that you are. With respect to exhaustion, ultimately, change providers, right? I will tell you that the conversation we just had was a peek into the world of minority patients, right? Because she's African, maybe African American, I'm African American, and we tell each other when we feel discriminated against. My data from the Just Medicine book and the qualitative interviews I did showed me that that is one of the key reasons that patients of color have discontinuity of care, are non-compliant, or I think a better word, non-adherent, because you sense this, it's exhausting, and you just don't want to be bothered after a while, right? So what you've just seen is actually supported by the qualitative data that I've collected, right? Not just African Americans. One of my favorite stories, I was telling you this about it earlier, is a first generation, actually an engineer that I interviewed from China. And he moved from China after having been a part of a labor camp during the Cultural Revolution. So he's a little bit older, and he is a very well-trained engineer working here in the United States in a university setting. He had a autoimmune disease. And if you read his story, you'll hear lots more about it, but here's the punchline. After not being believed because of his accent, after being talked down to, the fact that he was an engineer did not help this. After being told that the fact that his complaints couldn't manifest empirically in the biomedical data, he finally said, I stopped going. It was humiliating. It was not worth the effort. And so again, looking at reasons that we have health disparities, the causal connection that I'm suggesting in the book between these types of biases and the outcome of disparate health results has to do with this kind of interaction as well as it has to do with many other causes. Patients just get tired and we drop out.
Is there anything else that struck the audience?
Dayna, I haven't read the book yet. I have 2 copies, so I can read it twice. I just wanted to ask, but I will read it. I just wanted to ask a question. I was thinking back to when I read Just Mercy. And I read it on an airplane, and I think I was disruptive. I'm sure people were looking at me as I started to yell at Bryan Stevenson, the author of that book. I couldn't believe that this could be true. In fact, it couldn't be true. How did people do that and get away with it? This had to be 1950, but no, it wasn't. So I was screaming the whole time. It's a definite love-hate relationship with that book. So I was going to ask you if I'll have the same reaction. And I'm guessing no, because there's the word cure in here, so I'm thinking there's an optimistic piece.
You're going to make me tell the story. I sent the book to NYU Press with a very different title. And NYU Press is a phenomenal press, and they've worked with me a lot. And they wrote me back and said, you write the inside, we'll take care of the outside. And if you've worked on a book, you know that's not going to sit very well with you. So, when we were at the proof stage, they called me in and they had a group of people sit around and they said, the new title is, and this is the title. And I explained to them how come that wasn't going to work. It in part wasn't going to work because of Just Mercy. I said, I am no Bryan Stevenson, right? And we are not calling my book Just Medicine after Bryan Stevenson. And they said, thank you very much. Do you have anything else to say? And I said, about that cure word, that's not going to work either, right? Because I do have a prescription in there. I'm a lawyer, and so I'm yelling and screaming at lawyers mostly to change the law. Let me just say I left Washington very clear that I'm not going to get my prescription, at least for the next 4 years, right? So I'm on to another set of prescriptions at this point. But I was flabbergasted, and basically they told me, thank you very much for sharing, but you have no say over the title. I was embarrassed at first, and now I'm just sort of living with it.
So I fell into your trap.
Yeah, that's the title. I can't wait to meet Bryan Stevenson.
For those who have read, anything else strike you? Come on. And how many people actually read the book?
In the process.
Wrong.
I just happened to have read Blind Spot a couple months ago before I read this, so great timing accidentally on my part. And I know the book is older, but if I recall, it talked about implicit bias not moving much.
Yeah.
And so I was surprised when I read your book that you can change it, that there are ways to alter implicit bias. Do you think it's situational, or, I mean, can you actually move the needle through some of these recommendations?
So, I hesitate to say I take issue with the authors of Blind Spot because they really do know what they're talking about psychologically, right? Here's what I will say. Implicit bias causes discrimination, and you can definitely move the needle on the discrimination caused by implicit bias. All right? So what happens in your amygdala and what happens in the psychological sense is interruptible, is my thesis, right? I can interrupt that at various stages. I can train myself to recognize if, as I said to the question earlier, if I expect, because I am human, that I will have implicit biases, I can train myself to recognize the situations when they're going to manifest, all right? Clinically, they're going to manifest when I have to exercise discretion, a high degree of discretion. Clinically, they're going to manifest when I am in a disparate power relationship, patient-provider. They're going to manifest when I have to make decisions under time pressure and therefore look for shortcuts, heuristics to put people into groups and make decisions quickly. Once I have those expectations, then I can look at the interventions. So maybe the Blind Spot authors are right. The fact that these processes will occur automatically and out of my reach, that's true. I honestly, to be just a little smug, I don't need your heart and mind, I just need you to change your behavior, right? So I will say emphatically that something can be done about the harm that implicit bias causes. So I want to pause for a second. It is very, very important that although I'm not talking about express racism, that I make this point clearly, and I try to make it in the book. The fact that I've got the approach that takes you off the hook for explicit racism, right? You can say, I'm not a racist. Yes, you can say that. That's true. I don't want to take you off the hook for the harm that implicit or unintentional racism causes. It is as dangerous, as harmful, and perhaps more dangerous. And here's the empirical evidence to support what I will emphatically tell you is true experientially. A group of researchers led by Lewis Kenner does a wonderful job of looking at the combinations that are possible between explicit racism, frank bigotry, and implicit racism, unintentional racism, right? High-low, two variables. You can do a 4x4 and you can have combinations of high explicit bias, I'm a real bigot, and high implicit bias, I don't really want anything to do with you, right? And the combinations you can predict. It turns out that in the Lewis-Penner study, the combination that patients pick up and resist most vigorously, don't want anything to do with that person, not going back, find it exhausting, low levels of patient satisfaction, is this. Low explicit bias. I'm an egalitarian. I treat everybody equally. I love everybody. Some of my best friends are fill in the blank, right? Low explicit preferences. And very high implicit biases that people who have low explicit preferences don't think they have, right? So they don't think they have them, so they ignore them. They don't think they have them, and so they give explanations outside of their own behavior and intentions for whatever goes wrong in their interactions, right? They'll tell you that you're the problem, right? They will deny their contribution to any problem. Patients pick that up, respond to it as a matter of empirical proof, right? The worst of any combination of explicit and implicit bias, right? Since that's true, since we know that's true, what I'd like to suggest is that as healthcare providers, if you are serious at all about delivering high-quality healthcare to all, then you must confront the discrimination that you unintentionally cause in your communication, in your treatment decisions, in your body language, in your perceptions, yes, even in your statistical interpretation, right? Objective data, you read in the Wall Street Journal that there's an education gap, that blacks are not performing as highly on the SAT as whites are, that Latinos are far behind with respect to fourth grade reading levels. You read that. That is data. That is empirically true. You stored that in your amygdala, but you walked into the clinical encounter with your Latino patient, and that drove your expectation about whether that patient had the resources to do the treatment of choice. Whether that patient had the education, the wherewithal, that drove your perceptions as to whether that patient was exaggerating their pain. You may not have meant it, but you took true data and used it as background noise in your interaction in an individual encounter that may not have been true. We have data even beyond that to say that you looked at that patient's EKG output. You read their history and physical from the last encounter. You looked at the data that described their vital signs, and you read and interpreted it with the background noise of what you read in the Wall Street Journal. It colored that and changed your decisions about that objective data. So if we are in fact committed to moving the needle on disparities, indeed committed to making sure that patient care is the highest quality possible, then the introspection I'm asking and inviting is to recognize that unintentionally discrimination occurs because of your and my biases.
When you were talking about that study with, was it the green study you said? Has there been a study done between the physicians who are, recommending those processes of both, of all races? Is it just white? Does it have that inherent, like unintentional races, or do we see it with, Indian, black? I mean, what's the?
It's a lovely question.
Did everyone hear the question?
No, could you repeat that?
So
You guys
So the question was, do we see that unconscious racism in all races that are physicians, not just white physicians, but do we see it with black physicians, Indian? Like, what is the, what do we see with that?
It's an excellent question. Let me, before I answer it, just say one or two more things about implicit bias. The theory that I like better than the blind spot theory, yeah, there I said it, is that implicit biases are environmentally driven, right? So the music I listen to, the television shows that I hear, the movies that I see, the tone of the political discourse that I'm exposed to, experiences I might have had on the playground, my lived experience, experiences my friends have had, all of those environmental inputs influence my implicit biases. So in direct answer to your question, whether I am black, white, or otherwise, if I live in the United States and I am receiving the same environmental inputs, I am likely to hold the same biases. We have empirical proof of that, generally in the population and with physicians in particular. It is also of note that different types of physicians show some signs of having less or lower levels of implicit biases. Can you guess? Pediatricians, right? Pediatricians. Now, I will say that we don't have as good we don't have as good data on other specialties. And here's one real lack in the data. We don't know anything about nurses. We don't know anything about other clinical providers, PAs, pharmacists, dentists, and their biases. Here's a group I'm telling you we really got to study. The front office folks, right? Because they got bad attitudes. I'm not coming back. There are lots of places in the delivery care system or among the team where biases could operate. The data tells us that Latino doctors, let me do one more thing. One of the weaknesses in the implicit bias literature right now is the implicit associations test, the ability of that test to only do binary comparisons, right? So we only know if you are pro or anti-black and white, pro or anti-Latino and white. We can't do intersectionality, right? So I am not just a black person, I am also a black woman. If I am a black woman who's trans, oh my God, I don't have any real measure of the intersectionality of those various forms of vulnerability. Now, that said, we do know that black physicians have the same biases as white physicians. At about the same level, slightly less. Pro-white, anti-black. Yeah. Let that sink in. Confirmation for the environmental theory. We know that Latino physicians tend to have a higher, slightly higher, pro-white, anti-black bias than white and black physicians do. We know that female physicians tend to have a slightly lower pro-white, anti-black, pro-white, anti-Latino bias. Pediatricians the same. And we do know whatever biases operate at the beginning of your medical school training are exacerbated by the end of your medical school training, right? So we have two studies, and two studies doesn't necessarily, but they are confirming, right, that the level of implicit bias that medical students have at their first year is pretty much similar, or pretty similar to the levels of implicit bias that the general population of physicians in particular have, but that their biases don't influence their clinical judgment, which is nascent, obviously, because they're just beginning their training. Something we do over the 4 years brings them on aboard this discriminatory train, right? So that the bias levels don't change, but their treatment decisions and the correlation between their treatment and bias starts to line up adversely with the rest of physicians. So there's some work to do, sort of understanding what the educational system contributes to the ability to intervene and control one's biases as well.
I did actually have something that struck me. Given that this is, from a legal perspective, and you did mention you don't think we're going to get the change in the next 4 years, but that's okay. One of the things that I admit I haven't finish this chapter, but you mentioned that your proposed model would reward those providers who take preemptive steps to stop unintentional discrimination, and I was wondering if you could, talk a little bit about what those rewards would look like.
Sure. In the book, I talk about legal rewards, right? And so legal systems penalize by holding you liable and making you pay money. They reward by relieving you of liability, right? And so the legal system I propose at the end of the book is to say, in sort of legal speak, let's move from a strict liability standard to a negligence standard. Now, let me unpack that. That basically means that I will hold you responsible, make you pay money, for the discrimination you caused, only if you didn't do what social science tells us can be done to avoid it, right? So the reward is a defense. That's how we relieve you of liability in the legal system. A defense that would allow you to say, I took the literature that Matthew cited in this book, I kept up to date with it, I paid very close attention to the data about my patients and the results about the discrimination that might be occurring. I did de-biasing training. I had interventions like, I'm just going to use one that is really clearly in the literature effective. I had counter stereotypes, right? Counter stereotypes meaning I had a very serious recruitment and retention program so that I had people of diverse backgrounds throughout my system and on my team, from the highest paid, most powerful position to the person who had the lowest paycheck throughout the organization, right? If I could show those types of conscious decisions, then I would have relief, a reward in the form of being able to say, my defense is I acted reasonably. And the legal system would say you get a buy. So my hope was to incentivize a change in the social norm. The model I had in mind was one that imitated what happened around HIPAA. Who here does not know what HIPAA is? Nobody, right? Did you read the 2,000-page statute? No. But you are very aware, and your institution makes sure that you are aware of its privacy requirements. That's become the social norm around patient privacy and confidentiality. I would like to see a similar change in the social norm in healthcare delivery institutions around implicit bias, right? We assume it. We know its impact is harmful because it impacts the core mission of the institution to provide quality health care. We take responsibility institutionally for informing ourselves about the interventions that work, and we take reasonable steps to implement them. That's what I was hoping to accomplish by the reward system.
So, Sarah? It's on.
So how do we identify implicit bias that we don't know we have? How do we fix something that we don't know is broken as an individual?
That's a great question. First, we understand that there's no such thing as not having implicit biases, right? So part of the mission, and the reason I hold healthcare providers accountable is because you are what economists call the cheapest cost avoider, right? The institution can control the behavior and the outcomes much more effectively than any individual physician can, right? So I hold the institution responsible for knowing what I just said, that there is no such thing as not having implicit biases among my medical staff, right? Among my patients, among any humans connected with this organization. Secondly, I think the real important of your question is how do I fix it if I don't know where it is? What do I do about it if it's not there? So there's 25 years worth of literature that social psychologists call malleability literature. Malleability literature basically says that implicit biases, or rather the results or discrimination that come from bias, are malleable, i.e. I can do something about them. There is a way to do something to change them, right? Probably the most effective program that I have seen for health providers comes out of an organization called Cook-Ross. It is a implicit bias, unconscious racism consulting firm. I met them at a program put on by the American Association of Medical Colleges. Why do I like them? Because they do implicit bias training, not just as I'm doing, which is let's just talk about it and talk about the harms it causes. They do the how you change the impact, what you do about it for healthcare providers, right? So some of the things that you do include, and I'm just going to do a few examples. Some of the things that you do is you change the culture of your organization to both acknowledge and not tolerate what implicit bias is and does, right? That's a very top-down decision, right? We acknowledge that it occurs, we understand the harm, and we take reasonable steps to educate ourselves about what we're going to do about it. What are some of the things that clearly work? One of the things I already mentioned was counter stereotypes. We have a very active, aggressive retention and recruitment program so that diversity is reflected throughout the organization's leadership and throughout the entirety of the organization. Now, does that change the biases because I have black people that are as biased as white people? No, that's not enough. You can't stop there because remember, those black physicians, those Hispanic physicians, they get biases too, right? Secondly, after counter stereotypes, one of the things that we do know is that priming changes behavior, right? So remember the Green study where I said 67 of those physicians actually knew that this was a race study and their treatment decisions were different? Organizations can build in structural tools that will remind, i.e. prime people, about the dangers of implicit bias when they are about to encounter the types of situations that will foment, where bias is likely to occur, right? So what those are will change from organization to organization. I will tell you what a couple I heard in a medical school setting were. We have an app on our phone for our clinicians that they can use as they are walking into a room to remind themselves to check their biases, right? They've been trained, they've done the debiasing training, and this is a handy reminder of the evidence, this is evidence-based, that even after training, you're going to continue to get environmental inputs, right? Even after you've been made aware, you're going to continue to have onslaughts of conversations, of literature, and so forth. And so we train people just like we train them no longer to leave sensitive patient information available on the top of the nursing station. We train people to look at this quick, handy priming tool that says I'm about to walk into a room with a patient, I'm going to be biased, I can check myself and reduce my biases by just looking at this app, right? Lots of priming type things are available. Thirdly, another thing that's really shown to be very effective in the clinical setting is teams that check one another's decisions. Now, of course, you have to do the fourth thing that I would recommend. You've got to collect data, right? And it's got to be data that is stratified by race and ethnicity. So just let me flag for you, because I am, as the introduction suggested, an activist at heart. Right now, there is a bill in Congress to stop collecting race disparity data with respect to housing. Like a federal law that would say you can't do that anymore. It would be okay with me if you would call Senator Bennett and you would call Senator Gardner and you would let them know that those are not bills you'd like to see passed or advanced. If you want the actual, there's a Senate bill and a House bill number, then you can talk to me after. I'll be happy to even give you the number. You can speed dial it on my phone. But you've got to collect data and review it and respond to it institutionally about what the results are that you're trying to improve, right? This is a dynamic problem and it will change. What is the ratio of black to white patients who are getting recommended for transplant? What is the ratio of black to white to Latino patients who are getting the opportunity to stay off dialysis, who are getting the opportunity to, and you fill in the blanks, right? So that you actually are paying attention to the outcomes, right? That don't make you a racist, they make you a discriminator, not a racist, right? And it is human to discriminate because that comes out of your biases. If you are collecting that data institutionally, if you have changed the culture so that people respond to the data and they are not tolerant of that part of the data that can be explained by implicit biases, then you will find the tools that I'm describing, counter stereotypes, de-biasing training, and that's the last one I'll mention for right now, right? You'll find the tools that fit your organization. There's lots of other stuff you can do. When you make hiring decisions, they should be by teams. They should be blinded so that we're not looking at Shaquisa Jones and Lily Jones as the two resumes. We should blind them. We should review our composition of decision-making teams. We should talk about processes where bias occurs. Last thing, I think I'm up to number 5. De-biasing training actually works, and let me distinguish it from cultural competency. Let me distinguish it from cultural competency. And it was all we knew to do when we passed the class standards. They are effective to the extent that explicit or overt racism is the explanation for discrimination. They're not bad, they're just entirely ineffective with respect to implicit bias. De-biasing for implicit bias is a different kind of training. It recognizes the environmental nature. It recognizes the connection model. That is, I make connections about people automatically, and it addresses the habit-forming nature of implicit biases rather than the explicit prejudices that come from me not knowing what Cinco de Mayo Day is or something like that, right? So de-biasing training occurs over a long period of time. It includes a kind of engagement that's personal. I'm journaling. I'm having hard conversations with the people in the training with me. I am coming back and following up the ways that my own biases have expressed themselves. In other words, it is a kind of training that is designed particularly to the psychological processes that lead to implicit biases, right? So if an institution takes responsibility for doing that kind of intervention, we have reason to believe from the literature that the discrimination that occurs and harms patient outcomes from implicit bias in the clinical setting will change.
Okay. So in the book, I know, and I'm still reading it, but you talk about having to look at this from a legal standpoint, like as you've been talking. Or I guess, where do you see this legal, actionable thing happening when we're seeing, discrepancies in what the federal government's able to give as far as the science-backed information? The information is being shifted now, and then with the new Attorney General, possible Jeff Sessions, how do we see the ability to do these legal actions when we're seeing a shift in legal availability of information?
Yeah. So I'm going to take this opportunity to respond. I'm going to respond to that question by taking the opportunity to betray to you that if I were writing this book today, I'd write a different book, right? I'd write a book less about healthcare and more about population, right? I'd write a book about changing the outcomes rather than patient by patient, individual by individual, but population groups, right? I would also write a book recognizing the fact that I'm not going to get a change in Title VII in the next 4 years, which is the big change that I would like to see. Title VI, excuse me. The big change that I would like to see. Now, I have to quickly say that just because the environment has changed in my view, the truth hasn't changed. And so I'm going to continue to advocate for a change in Title VI of the Civil Rights Act, that it should reflect implicit bias as well as explicit bias. But there is right now, and I'm conflicted about talking about it, there is right now a new set of regulations that passed before the Obama administration left the Health and Human Services Department. It's called Section 1557. Section 1557 creates the kind of regulatory environment that I think is ripe for incentivizing a change in the social norms in institutions like this one, right? So Section 1557 does what I would have liked to have seen Title VI do, in that it, three things. It restores what's called a private right of action, right? So for a lawyer, you get a smile. I used to practice law. I used to sue people for a living. I still consider that kind of fun. I know it makes you break out into a cold sweat. But it is the nuclear option. And it provides incentive for the rest of the changes before you get to litigation to occur. So 1557 does one thing. It restores a private right of action. Secondly, it defines that action not by what is intentionally discriminatory, but what has a discriminatory effect. All right, that's legalese. Let me make it English. It used to be, before 1557, that the only kind of prohibited behavior was if I intended to be discriminatory against you. How do you prove that? Think about it. Think about a legal show where you have somebody on the stand and you're trying to elicit from them an affirmative answer to the question, did you intend to discriminate? The answer is going to be no. I can't find a memo. I can't find a conversation. People don't talk like that anymore. Those were impossible suits to win. And so the discrimination law was ineffective. What 1557 does is say, I don't have to get you on the stand and say that you intended to discriminate. I can look at the data and see that your outcomes were discriminatory in their effect. Right? So I can make a statistical case that whatever you intended, let's say you were the kindest, puppies and rainbows, you were the kindest, gentlest, most wonderful egalitarian in the world, doesn't matter, your outcomes still are highly disparate from the standpoint of groups that we are protecting. I now have the authority under the Section 1557 regulation to say that the results show me in effect that your otherwise neutral actions are causing disparate outcomes. That's actionable, right? Now, if all I had was the ability to sue you, I'd have a very low likelihood of really getting change. Here's what the third thing that Section 1557 does for me. It creates an administrative environment where I can call somebody to account for a discriminatory impact and then negotiate changes in their processes, their operations, and their procedures, right? So it's called a voluntary, if you're nice, involuntary, if you're less nice, or negotiated settlement, right? So I have somebody to tell, right? I can go to HHS and I can say, I want to file a 1557 claim. I'm not suing you. I don't have to find a lawyer to do that, right? I want to file a 1557 claim, and it starts the conversation. The reason I like Section 1557 is because I think we only have to have a couple of these conversations, right? And the word will get out. That now we've restored disparate impact, the effects, as opposed to the intentional. Now we have restored so that unintentional as well as intentional discrimination is actionable. Any of us want to litigate this. We're not going to litigate everybody. Like I said, I don't need your heart, I don't need your mind, I don't even need your money. I just need you to stop and think about the grave detriment that implicit bias does to patient.
Let's take one last question, and then we want to have time for Dr. Matthew to sign books. And then there's also going to be another lecture at noon with box lunches.
I don't know if you can hear me.
Okay. This is like my third book signing of yours that I've attended, so I'm not stalking you, but it's just a reflection of how much I enjoy you. So I had sort of two questions. One is, when I look out to this audience here, I don't know how often you come to the Anschutz campus, but this is not sort of the typical reflection of how an audience looks at most talks here on this campus. So part of my question is, one, how do you disseminate this message to folks that are not exactly the choir, so to speak, the people that kind of already have a great appreciation for the value of examining implicit bias? And then my second question is, when I was in medical school, I had a phenomenal mentor who was Orthodox Jewish. He was a practicing physician at Johns Hopkins for about 4 decades. And for the life of him, he couldn't understand why there were Black medical interest groups, Hispanic medical interest groups, LGBT medical interest groups, because from his perspective, he saw medicine as kind of one of those unique arenas where, at least in theory, we're supposed to be looking at the human body in a very unobjective way. Is that right? Yeah. Unsubjective way, objective way. And so he, from his perspective, he felt like opening up this box where we are sort of separating ourselves to an extent can be divisive, particularly in the field of medicine. Like he saw medicine as being sort of unique to like a marketing field or arts and cultural field. He saw medicine as being sort of this very unique place where all cultures could kind of be almost monolithic in their approach to patients and be successful. And this is sort of piggybacks to this gentleman's question, particularly as we're kind of entering this new realm and this new administration. How do we convey to folks that appreciating differences and acknowledging differences is actually a strength, instead of from some generation of physicians teaching and educating students, you know, when you walk into an examination room, don't look at this person's color or gender, or, you know, just identify their disease need, let's say, and address that without introducing potentially even more bias into a patient-physician interaction, if that makes sense.
So both hard questions at the very edge of what I know we have done and sort of launching into what we have yet to do. For your second question, I would say it's really important that you are able to communicate data to your friend, right? So we talk about evidence-based medicine. One of the exciting things about the implicit bias literature is that it is mature enough at this point that we can make evidence-based decisions that will dissuade your friend from thinking that color blindness works, right? Another book, by the way, Colorblind, got my issues. So there are enough data and enough studies, if only we look at patient satisfaction numbers, right? If we don't look at anything other than patient satisfaction, right? First question out of the box. I've experienced it, makes me dissatisfied. Hospitals, health centers, providers generally are responsive to patient satisfaction, and looking behind where the patient dissatisfaction is, if you are bold enough to collect the data, will completely contradict your friend's notion that there is no bias and that we have this objective world in which medicine can operate. All right? As to how we get people beyond the choir, I will say, a friend was kind of asking me, am I getting the word out? I feel as though this was an opportunity to test the waters for what kind of an appetite there is to ramp up the communication a little bit, right? And when I say a little bit, I actually don't mean a little bit. I mean ramping up the communication so that we do a couple of things with the evidence that we have. We say to people who care about patients, who care about quality and who care about reputation, all of these metrics that you care about are suffering because we are not paying attention to this variable, right? We educate people who, let me be careful about this. Let me not be careful about this. So we educate people who are still thinking that diversity and inclusion is enough. Okay? Remember I said counter stereotypes are one intervention that work? They are not enough in and of themselves. So, a major hospital here in the state of Colorado had the occasion to talk about an ugly racial incident. And we all got together and had that kumbaya conversation and said, how could this happen here where everybody is so good, so well-intentioned, so well-meaning, where we do so many things for the very victims that suffered this racial indignity? How could this happen? The answer to how it could happen must lie in something you haven't hitherto perceived, something you haven't up until this point addressed, something that does not get touched by the cultural competency and the very important interventions that you've done. You have to be willing to look at something that you didn't see before, implicit, unconscious racism, right? I cannot tell you that it was easy, but this hospital actually said it's going to be bumpy, it's going to be scary, because we're the good guys, right? We're the people who care. We're objective, we're caregivers, we really intend to do the right thing. But something's not working here. So getting the message out is in part confronting the status quo and saying what you've done thus far, data tells me it's not enough. How serious are you, institution? How committed are we, healthcare system? How important is it, public health providers, to really change the population impact? And if I had time, I would tell you, this is the last thing I'll say. So that's the quick answer. The population impact is where we really need to go, right? Because implicit bias, this book is all about the interaction between provider and individual patient, right? I've tried to take it to an institutional level by calling the health institution the cheapest cost provider. But if you think about all of the social determinants of health, which we know are 40% responsible for health outcomes, housing, education, food security, employment, all of the health determinants are plagued by implicit bias, right? So if we really want to change population health, we've got to do something about redlining and gerrymandering. We've got to do something about the disproportionate extent to which Black boys and Latino boys get disciplined from 3 years of age, right? Because that sets them up not only to go to prison, but certainly to have poor health outcomes. We've got to do something about the housing disparities that are rampant. And in my observation, I've just been back for 3 weeks, and I'm like, wow, affordable housing is like a thing of the past in Denver, right? We know the connection and association between a lack of affordable housing, between housing instability and health outcomes. Those are the problems that we have to be looking at from all angles, including the implicit bias that affects the distribution, unequal distribution of the social determinants of health. So that's what I would be writing about and talking about now, because now I understand a lot more about taking population health and making that the center of my attention. So, different book, coming soon.
Thank you so much. If you don't mind, maybe people can just line up down here. We've got some pens. You can bring your book. Or multiple books.
I was hoping I could see you, but you had such a sexy haircut. I didn't recognize you from your dad. I'm like, who's this?
Yeah. Mark, I want to come over here and have a tongue.
You do. One on each side. And they didn't even have it. So did you think it was working? Or did you buy it? We're setting it up. Was one of the first people that lost it. Oh. Did you buy your own? I think you better do two sides.
So I got there about 20 minutes. I'm doing my Wow, what were they doing? Arguing with each other? There you go. Were they mad? Sunday.
Because we had a
Sure.
No, we actually had it. Oh, okay. I brought it. So people come by. I got it.
I figured you'd have to come.
Yeah, three of them are working in a group together. The professor was like, oh.
You're all different.
Yes.
Oh yeah,
Yes.
Do you want to go somewhere?
Yeah, I know. Y'all release next week.
Excuse me. You're not Jesse by chance.
I am.
Oh, you are.
What can I do?
Can you help us with transportation
Yes.
from this building to the...
It'll be a shuttle. It'll be like a golf cart.
Okay, say that again.
It's like a golf cart.
Oh, fine, that's okay. You said riding those, and up at, since I said it, riding those up at Estes Park, the Salvation Army campground.
Okay.
Ford Motors gave us a half a dozen of them to ride around up and down the hills.
Good.
Yeah. So, how do we arrange this?
Okay,
Where
so
do we meet at the show?
I'll have you just stay here.
Okay.
And then I'll call them when it gets closer to the end of the lecture.
Oh, okay.
And then they'll call us.
Okay, then all right. Very good. Wonderful. All right. Thank you so
Yeah,
very much.
thanks for coming.
Oh, I'm so glad I came because I hesitated. I had another very important meeting at the public library today, scheduled for Living Wills.
Oh, yeah, that's important too.
And I thought I'd need to go there, but I've been to several of those meetings years past.
Okay.
And I've done fairly well. Right thing.
Good.
Yeah. So I thought I pulled away, and it was a big pizza day.
Yeah.
For senior citizens, and someone else in my building is going to it, so I thought I better come here and support this.
Good.
So I'm glad I came.
Are you vegetarian? Do you
No,
prefer salad?
Salad with or without the sandwich? Yeah.
You want a sandwich?
Right. Oh yes.
Any kind of meat?
Been trying to eat which kind of meat. I usually don't eat ham, that's what I eat it without hours.
Okay, so some sort of turkey. I'll find it. Tuna?
I think I'd rather have tuna.
Okay.
Okay, but I have that at home. They don't have ham, right?
Or do you prefer ham?
Ham is first choice.
Okay.
That's the only time I eat it, usually when I'm out. It tastes more real than the other meats.
Yeah. Now, what kind of soda? Diet Coke or Coke?
Coke.
Coke?
Coca-Cola.
Yep, I have it.
And it says on the 16th, this is another meeting that's held by 2020.
24 hours a month. They need like 20, 40. There are lots of different and I love that I applied for a couple of them, like SMNA, scholarships, and organization which I applied for happened and the success and stuff like that. It is important. Like, it is, like I said, it's sport. Like, as much as we want it not to be, even if it is, the only way going across sport to really try to hit numbers. Until we have how we compare students. It just tells you how well you do. It tells you how likely are you to crash. Are trying to pull together a big group of people and how to promote it's going to take all of it. It is. It's like one of those. Oh my gosh. Yeah. She first to say, where did we next go? We went downtown at Shamali. I'm getting there. It's 2 years out. And like, late. I do. John's kind of fruity. Yeah? She has info. Yeah. Taking the round. She knows all the good work for that. How are I know, because I remember
Getting to the front. We're almost there. We just, this edition, so we're like straight up. Yeah.
So let's
yeah, I was wondering what he was going to be talking about.
He's not ready now.
Sat on and was like right up the starting and figuring out what is this salon thing and how do you do this? So guessing things
Like direction that you can.
At least not the way I had to really again, I have like this much understanding of that.
Yeah.
I didn't bring a pen. I hope she has
Oh my goodness, it was I mean the series. I feel like
Hi, Katie.
Good, how are you?
Oh, yeah, I'll be over there.
And Tim just walked back with a bottle of water.
Where'd you get water from? There's water.
Water over there.
There's some on that. I thought there was some on that side too when I walked back.
I was so focused on the food.
Yeah, I was talking to Tim about how much you like food.
No.
It's my favorite thing.
And then she's ready to leave the line and get food to make food.
Yeah.
I'm gonna have to put my food in the fridge. I forgot that I was getting lunch today.
I want to change everything about this work.
I like Raptor though. She just needs to do objectives.
But think about how much better.
I mean, I don't know. That's his area of expertise. I don't know what it would be for everything else.
But he's like easier to follow than what.
For ECGs.
You know who I really like? The kidney guy for pathology.
I don't remember him.
Did you guys like the liver lady?
Yeah,
Everything that we
I think
said.
this is if you listen to order like see how you can watch it from like live stream or whatever.
I'm ready. I mostly went for the sides. I'm not a fan of my sandwich.
What sandwich did you get? Olive?
Yeah. But I really like the side. I think it's more like olive.
Oh yeah? Did you see another sandwich that you want to try? It is.
It's very
Sometimes even the ones on the bottom.
Yeah, they all have different sides. They're the same side, just different sides. Yeah.
See, I feel like it's really hard for me to communicate this information. Well, I was going to say, you should do
Right?
Yeah.
I'm showing you those people, so I'm like,
I'm fairly
All the.
I'm sorry.
Yeah. Yeah. So the internship, like I started like streamlining runs into me. Yeah. So it's all dependent on, right, it's all dependent on like whether I'm doing a job like somewhere here. It's, yeah, just wherever I have a job. It's kind of all things for like, recognize it, that would be nice, but if not, just wherever I can. No, like, I mean, that is home. It is home. It is home. Yeah, my family's all there. Yeah.
Are they like surprised when you do it?
Originally, like, the reason why I wanted to move to the States is I was interested actually in opportunity. Yeah. So that's why I wanted to come here.
Most Americans
Hey, thank you. Hello, hi. Good. Good to see you here.
I've seen you.
Thank you.
Dr. Leah Mitchell and her.
All right, thank you. And you are Kate. Kate, my pleasure. I'm Barbara. Sorry, Kate. Quite all right.
This is everybody.
What's your name? Regina. Yes. I came up here when I saw you.
Yes, so very good. Hi, how are you today? Very good. I'm very good. I'm Barbara. And you are my mother's name. Kanisha. Beautiful. Do you know what Barbara means? Barbara. What do you know what the meaning of Barbara? Does you and Mom know that? The Bible book story is the bringing of joy. The coming or bringing of joy. I'm coming or bringing of joy. And Regina. Yes. I know her from Regina. Yes.
I was going to say, is there an annual one that they put on every year?
Down in Quebec?
Yeah. Yep, at the Renaissance too. Yeah, bigger sometimes.
But yeah, I was with 24 Partners when I first got started. And did that for a couple of years. So
Younger lady,
do you think you pull my little face for me?
See,
They do make it kind of hard.
Very good, thank you.
So that's what you all continue to do. Yeah, keep it up. Yeah. Did you enjoy
Oh, it was great.
Did it just give you extra pride? Did it give you extra pride that she's a black woman?
Yes, extra pride. Have you heard of it?
Oh yeah.
Oh,
she has a colleague in print.
Oh,
yes. So, she's incredible. Dayna. Yeah, Dayna. Khadijah always undersells herself. She's a physician. She's a doctor.
What area?
I love Mama.
Amen.
What area are you in?
Cardiology. Heart doctor.
The heart doctor. So humble. So smart.
Give all the glory.
Hallelujah.
I finished med school.
I have a question. Y'all were talking yesterday. Ethical program. Were they actually the heart? See what's going on in there? Can they also call what you might have?
Not with that type of machine, but with a blood test. I've seen you go to church. Where do you go?
I'm traveling around. I'm going to Sunday evening. I go to Mama Billy at 3:30. In the morning I go around.
I'll be free. Yeah. New Hope and Zion on February 18th at 10. So you want to come? And it's like a go-in church, but it'll be at New Hope at 10 a.m.
Oh, Sarah?
Yes, ma'am. February 18th. And I'll be talking about cardiovascular. It's on their website. It's at New Hope.
Oh, I know what 3701 called.
But it'll be February 18th, I think. I can ask all the questions.
And then the other piece is I engage with someone and looking at
Smaller plates.
and they have their questions.
So you'll recognize what vegetable it is. And then another quarter of the plate should be like fiber, so it exists brown rather than white. And then you can do it like
Alicia Lewis. You remind her so
Every day. As I lay awake last night, she's not you just got to
Yeah, we moved it like a year and a half ago. Our pastor. We're on East Iowa. That's right. 4625.
that's about Colorado, like this. Yeah, it's like a block away. Alright.
I'm visiting sometime.
I can hear church. Oh, really? But the old educational building in Colorado. I decided our church folded last year. So I decided all the ministers, I did so much around here.
I need a hug. I need a hug.
We'll talk after. That's how I heard it on the radio. Oh, yeah. Thank you.
I saw it.
Look what I mean. You don't even notice. I have tried.
Smile. I'm back.
Will they ever get back to we started out was it orator or was it essay? We started out with I thought I had some Keep going. No mustard. My meat without it. But today I wanted something on my meat. Yes, side by side. 3 on through side by side.
I think it's because
I didn't notice it when I was playing.
I'm so glad you guys. So I never
I seem to be well mixed.
These are my colleagues from the social by the way.
I'm rarely able to buy him and share him at home. So when I'm out, I usually order him. And Sam. I don't feel to it, but I believe that every good diet is a lot of this, some fruit, and a little meat. It keeps that in diabetic class. I have not been doing that February. February 25th. We're doing so much with health, communities.
That's absolutely not all. I'm happy about this. It is. It had no electricity,
Oh, yeah.
It's my wife, Michelle.
Right there in the middle. We saw it in Hennessy. He was
He wasn't sure if he was How about you? What are you doing this time?
oh, yeah.
Two things you could do to learn language.
I heard about that.
Am I using really big hand gestures?
Me too.
You get it? It's like I was way out of tune. And she just
Were you there?
You're like.
And never nothing about
Oh yeah, about. I'm probably almost 60.
Oh yeah, but have you seen before? They have a lot of things that they're
I know they were eating very surely going to
Oh, were they? That I was going to thought about I was surprised. There's 3 lecturers right to
Oh, really?
and they study one of them I know is it's really good.
This is like the education building.
This is the education. That's also in the study hall and just study area. Thank you so very much.
Yes, if you need anything else, let me know.
Hello again. I had to leave before the last session was over. I wish I had.
Glad you made it.
Oh, me too. Frank?
There's not a pointer, is there?
Are you a member resident of Denver?
I am not. I live in Boulder County.
Oh, you did in Colorado?
In Colorado, yes. I live in Boulder County in a small town called Niwot.
Oh, wow. But I bet it's fantastic. I want to ask you another question.
Yes, ma'am.
I don't think so.
That's okay.
That's okay.
Yes.
We're members 10 years plus of a group called Afro-American Caregivers to take care of people. At least 60 and over.
Yes.
That's really because of the grant.
Yes.
But we meet on Wednesday at the library in Northeast Denver. Library.
Yeah.
Consider would that be all right. Give me a contact number.
Yes, I will.
Love it. There's about 30 to 40 of us.
Excellent.
Okay, very good. And most of us are seniors ourselves.
Yeah, there's a nice question.
All right, thank you so very much.
Hello. Welcome to our February lecture. Distinguished speaker today is going to live up to the tradition, I'm sure. Louis Levitt was a physician in Denver. He was born in 1896 and went to veterinarian school, then went to medical school, graduated in 1927, practiced for 40 years as a general practitioner and a family practitioner in Denver, at which time he retired. And when he died in 1978, he bequeathed a small endowment to this Department of Family Medicine for us to invite distinguished speakers to the campus and to the general community to inspire us and instruct us and enlarge our thinking and make us better than we are. Help us do more good than we were otherwise doing. So I'm Frank DeGree. I chair the Department of Family Medicine. I'm one of the people who passes through and have the great good fortune of introducing and enjoying the Levitt speakers during my tour of duty. And today, I have a treat for you. This is going to be so great. Our distinguished Levitt lecturer today is Dayna Matthew. Dr. Matthew is a professor at the School of Law in Bowen, University of Colorado. She also has an appointment in the School of Public Health here on this campus, as well as being a member of the Center for Bioethics and Humanities building right there on this campus. She does a lot of other stuff as well. She's on the board of directors of the Farley Policy Center. She's just getting back to Colorado after having spent a She's been a special advisor to the director in the Office of Civil Rights for the EPA, for the Environmental Protection Agency in Washington. And she's just recently completed a health policy fellowship sponsored by the Robert Wood Johnson Foundation in Washington. Dayna has, she's the co-founder of the Colorado Health Equity Project, which is a medical legal partnership whose mission is to remove barriers to good health for low-income clients by providing the legal resources that represent barriers to health. She's practiced. She's a practicing lawyer. She knows how to do that too. She carries that card. And for those of you who weren't able to be here for the last hour and a half, otherwise you would know that she's just recently published a book that's called Just Medicine, A Cure for Racial Inequality in American Healthcare, which mostly deals with implicit bias and how implicit, as well as explicit bias, racism, sexism, impairs health quality. Beautiful book. Go read it. But for the next hour and 15 minutes, that's not what she's here to talk about. As you can see by the slide that's up right now, she's going to talk about preventive lawyering. She's going to talk about medical legal partnerships and how those kinds of partnerships can improve health outcomes as well as social outcomes which are related to health outcomes. In other words, as we begin to think about population health and social determinants of health, how we expand our teams to improve health, Dayna is going to probably convince you once and for all that an indispensable central feature of that partnership, that team, needs to be lawyers. She's going to spend a lot of time on how, so I don't mind doing a little bit on what. Oh man, I am so inspired by this woman. I want to be Dayna Matthew when I grow up. Please join me in welcoming Dayna Matthew.
That's a really hard introduction. Thank you for taking the time to talk with me today. Before I get started, just so that I know how many of my way too many slides I should cut out, how many of you already know and have experience with medical legal partnerships? Oh, you're going to get every one of my slides. I'm sorry. All right, so I talk at the speed of light. How about if you let me get all the way through the prepared remarks, and then we'll ask and answer some questions at the end. That way I get to set up everything. Even if I leave you confused with something, just jot it down and we will continue on. So I do need a clicker. I don't see one. Sorry. So I'll just, that means I have to stand here. You have no idea how hard this is going to be. Okay, I want to start. Thank you. There's no way I can stand still.
This is the clear. I don't know how to grab it.
Dayna.
Thank you, ma'am. Okay, so while we're getting the clicker synced up, let me just go to the first slide. This is a picture of, I'm going to call him Baby Eduardo. He was a patient over at Children's Hospital and also a client of the medical legal partnership that we call the Colorado Health Equity Project. I put his picture up along with his lawyer and not his parents. I'm just going to tell you a little bit about the work that we did with Baby Eduardo. He was born with a congenital defect. You see he's wearing a trach. And so he had very expensive medical needs that, apart from being able to be covered by Medicaid, he could not have paid for. His parents were not documented. So although we had permission to use his photograph, we couldn't photograph him with his parents. So when we met him, the charge that we were given was to see if we could get him financial coverage for the health care he needed to get him to age 3, when he could have an operation that would have made him independent of any kind of machinery, medical devices, healthy, normal 3-year-old young boy. The good news is we did take care of him from a legal standpoint. We did partner with the physicians and his care team over at the Children's Hospital, and his health care was insured. Over the course of the 3 years, over the course of the 3 years that we worked with him at the Colorado Health Equity Project, other legal issues arose as well. As I said, his parents were undocumented, so getting them access to health care was an issue for us. There was one parent we were able to bring into status. The other parent we could not. So the legal rules allowed us to bring one parent into status and allow them to get health care coverage legally, but the other parent we could not. Here are some of the problems we could not solve. The parent we could not bring into status was employed as a day laborer. So there were times when he was exposed to incredible levels of real, frank discrimination, where he would go out and work a whole day and not get paid at all. We couldn't really do anything about that, although there are laws on the books. Had he been documented, we could have done something about that. Other problems that we only partially solved, they were being evicted and threatened because of their documentation status. They were being evicted illegally, right? So we were able to come in and do what lawyers do, put the fear of somebody in them, and we kept them in place for a while because their instability residentially would have harmed his health. We kept them in place for a while, long enough for, and I have to credit my students for this, we have a medical legal partnership that is staffed mostly by law students, along with volunteer lawyers like Siddhartha Rathod there. We were able to ultimately move them to affordable housing, right? So that gave them housing stability. But we staved off the eviction for a while. We could not do anything about the frequency with which the undocumented parent got picked up for driving while browned, right? We couldn't do a thing about the fact that we, during the course of the 3 years, had to show up at the jail, bail him out, and try as we might, we couldn't stop him from getting picked up for a tail light out or other kinds of things that were clearly harassing. So I want to say that although I'm going to talk passionately about medical legal partnerships, there are some things we can fix and some things we can't, but we can make health outcomes better if we work together. So I'm inspired, this is Black History Month, I'm inspired by this photograph to tell you that what I am talking about can be boiled down into one thing. I want to talk about the power of truly integrated health. Truly integrated health includes a very intentional address to the social risks and the social drivers that impact health. Now, I'll state a statistic, and I bet most of you already know it. When we talk about what determines health outcomes, how many of you already know that 40% of what determines health outcomes has nothing to do with genetics, nothing to do with biology, nothing to do with clinical care, but it has to do with social and environmental factors, 40%. The truly integrated healthcare practice will address that, will recognize that, and understand that healthcare is not truly going to be effective unless it includes lawyers. So here's Martin Luther King saying, so what are you going to do about it, Dayna? And I am going to suggest that we consider true preventive lawyering as preventive health care. I'll tell you why really quickly, just to make sure that we are all talking about the same problem. Then I'll talk about how we would intervene with medical legal partnerships. I'll define them and explain some of the data that tells you about their effectiveness. Then I will end by saying you too, if you are interested, have a role to play and could do some things tomorrow. In fact, as you walk out of this room, if you're convinced by my argument about preventive lawyering. So this data I know is familiar to you. I just want to identify the populations that I think are most helped by preventive lawyering, or medical legal partnerships as I call them. Preventive lawyering helps people who are low income. These are some of the data of the people in Denver and Colorado that medical legal partnerships could be targeted at. People with median household incomes in Denver are lower than in Colorado overall. But when you look at people who are low income, we have a higher rate of child poverty in Denver and in Colorado generally than many states in the union. In fact, last I looked, we had the fastest growing poverty rate, and it slowed down. We had something near the fastest growing poverty rate in the nation. I'm not sure if that's true anymore. We are interested in vulnerable populations who are young. We are interested in vulnerable populations who are residentially unstable. We're looking also at populations that have chronic diseases and other medical risks. These are some of the data about populations who suffer early death, children who suffer early death. We look at populations that don't have access to health care. These populations not only fail to have access to health care, there is a large number, 8% seems too large to me, 10% in Colorado, a large number of Colorado's population that has eligibility for health care coverage but is not enrolled. That's a population we can move the needle on. We can improve their health outcomes. And we can improve health outcomes for populations that are minority by race and ethnicity, and therefore are also associated with other social drivers, low performance in education and so forth. These are the populations that we're interested in. It is not a small number of people who are low income, vulnerable, and exposed, and have the poor health outcomes to show for it. But coupled with their poor health outcomes, they also have a very limited access to justice, a very limited access to lawyers who might help equalize their access to the social determinants of health that I talked about. So look down at the bottom, the determinants of health in Colorado. Hunger and food insecurity, 12.1% of the Colorado population suffers hunger and food insecurity. The reason affordable housing and health insurance coverage are circled in blue is because I do have an empirical study going on right now looking at whether the medical legal partnership intervention actually improves housing stability and coverage so that it results in a more regular access to preventative care. Those are two of the social drivers that we are looking at empirically. But the population we're looking at is low-income, vulnerable patients who are reporting poorer health than the general population. So we have the social gradient in Colorado, just as we do in the rest of the country, that low-income Coloradans are more likely to report or self-report poor health than high-income Coloradans. And that's from a general as well as specialty health perspective. So that we're also identifying the same population. It's important to understand that low-income, poor health outcomes are racialized in Colorado just as they are around the country. So you see here with this graph that Black Americans, Asian Pacific Islanders, Hispanic Americans have lower incomes and report poorer health as well. These are the vulnerable populations that not only have poor health outcomes, but again, let me repeat, also have a limited access to justice. How does this manifest? I'm going to just use one health statistic or one health outcome that I think is generally persuasive and will give you the point. I could spend the rest of the hour talking about disparities along income, disability, gender, and other vulnerabilities. I'm going to use infant mortality just to, again, identify the population and the health outcomes that we are interested in improving with preventive lawyering. So we know in Colorado that the rate of infant mortality for African American babies is almost 3 times higher generally than it is for white babies in the state. We also know that when we control for income and education, that disparity does not go away. So a low-income white mom loses her baby at about half the rate as a middle-income black mom, and at almost half the rate as a middle-income Latino mom. That tells us that here in Colorado, just like in the rest of the country, some of the health disparities and some of the problems that we're looking at of inequality are not only socioeconomically driven, but are also racially driven. So that's another population that we're looking at. And with respect to racial and ethnic minorities, we're not looking only at low-income populations, but we're looking at middle-income populations as well. Some of this data confirms why. Again, this is national data about infant mortality. As education increases, so that a black mom with college education is compared to a white mom with less than a high school education and still has a multiple number of infant mortality deaths that a white mom does, that means we have what's called, again, in honor of Black History Month, a race problem, right? So this is just a picture of Frederick Douglass. If you haven't heard his speech called A Race Problem, it's short, it's worth listening to. I can't play it for you because that's as much of this part of the presentation that I can actually argue is relevant. So let's talk about the medical legal partnership intervention. It's based on the theory that 1 in 6, not the theory, the understanding that 1 in 6 Americans has a need for a lawyer in order to be healthy. So let me say that again. 1 in 6 Americans has a need for a lawyer to actually have the opportunity to be healthy. Now, that's not an ordinary association. You wouldn't have made that leap immediately. How can that be, and how does it occur? There are medical legal partnerships around the country that are serving a group of needs that we abbreviate by this acronym called IHELP. I'll come back to this slide, IHELP. IHELP stands for the body of cases that vulnerable populations need lawyers to solve in order to be healthy. I'm going to go through some of them, but just to tell you about the acronym: income cases, housing cases, education and employment cases, legal status cases, and personal safety cases are the body of legal problems that people who are low income, that I described in the first part of this presentation, need help with in order to be healthy. Are you waiting for me? No. Oh, okay. I'm sorry. Okay. Welcome. How does a lawyer help you be healthy if you have an income problem? I'm going to do a couple of these just to make the case, and then after that, if you're not convinced, I'll do all of the IHELP acronym. We know from Raj Chetty's work that there is a clear relationship between income and life expectancy. So this graph just shows us the association between having a low versus high income and what your life expectancy will be. That's true in Colorado as well, as I showed you earlier, that people with low incomes report poor health more frequently than people with high incomes do in Colorado. So what can a medical legal partnership do about that? There's a fair amount of data. I've got 3 studies shown here, that when a medical legal partnership intervenes in order to guarantee already legally enforceable rights to income supports, to equalize income distribution, that the result is a higher degree of self-reported health and better health outcomes. Part of the reason for this association may be simply that when you have enough income that is disposable and can be spent on health care, you can take care of your health better. Part of the reason or explanation may also be that not having financial problems reduces the stress that you experience that's detrimental at least to your mental health and possibly also to your physical health. But these 3 studies, for example, show that in very, very limited circumstances, we have seen that a medical-legal partnership intervening to provide supports for income, you will find that better self-efficacy results, so that in the Siege study, there was an increased uptake of public benefits. More people in the Weintraub study at Stanford showed improved health behaviors so that we can associate a social risk, low income, with the likelihood that people will participate in or engage in better self-behavior. So we saw lower levels of smoking, lower levels of sedentary non-physical activity. We saw higher levels of attending preventive health care appointments in the Weintraub study. Stuart Fleischman in 2006 reported with respect to cancer patients in New York City, when a medical legal partnership intervened in order to provide income supports, access to public benefits, and counseling with respect to employment, 75% of those cancer patients reported lower levels of stress and had better health outcomes on a self-reported basis than those who didn't in a control group in that same study. So we can definitely see that with respect to income supports, there is a fair amount of evidence that in small studies, medical legal partnerships make a difference with respect to health outcomes. Now, one of the things I would like to talk about at the end is the fact that this research is nascent, that there isn't enough of it. So when I said you could walk out of this room and help, if you're convinced of the connection between legal services and health outcomes, you can help. And I'll show you how with respect to more research. The second of the category of legal cases that I talked about, housing cases. These are cases like Baby Eduardo's family faced. Illegal evictions, substandard housing problems, utility turnoffs. We have evidence, and that's described by the slide behind me, that the number of people that are experiencing moderate to severe housing problems, that is leaky plumbing, moldy housing, things that have direct health impact, increases as your income decreases. These are, again, the people that we are targeting with respect to medical legal partnerships. Why? Because the rights to decent, clean, safe housing exist and are enforceable by existing laws on the books. But remember, this is the very population that has the least access to a lawyer, right? If you and I are being unfairly charged by our mortgage company, or our landlord is not repairing a housing problem up to code, we call a friend, we call a lawyer, we have access to a legal intervention. This population suffers the health impacts of substandard housing, the health impacts of utility cutoffs, but they have no access to a lawyer to enforce the existing law. The phrase that medical legal partnerships often use is called making the law on the books match the law on the streets. So we don't need new laws. We don't need to go out and change existing statutes and regulations. We only need to give access to the existing laws to this population whose health is harmed by their substandard housing. One of the best studies is done by a woman named Kathleen O'Sullivan. Dr. O'Sullivan did a study in New York City of populations that were in a housing project. She actually sent in medical legal partnership participants to intervene with respect to bringing those apartment buildings up to code. So there was lead paint violations, there were mold and sanitation violations, and she took care of those, and at the same time did pre- and post studies of the asthma patients, child asthma patients, who were resident in those public housing units. It was a wonderful study to begin to show that the difference that a medical legal partnership makes is not just in the social environment, but also it showed up in reduced dependency on steroids, in reduced numbers of hospital visits, hospitalizations rather, and emergency department visits for the children who had asthma in the study. These are the kinds of data that are beginning to convince us that an important part of health is making sure that vulnerable populations have access to lawyering in order to be healthy. That's O'Sullivan's study at the bottom, performed in 2012. I want to bring one other study to your attention, and it was done by Dayna Hernandez in 2016. It just came out, and it's a mixed method study that includes interviews with low-income families comparing to a control group, those that were randomly assigned to an intervention that included a lawyer, a medical legal partnership, and an intervention that included other professionals. I'll pause here before I tell you the outcome of this study because it's important that truly integrated healthcare includes lawyers but not just lawyers. In our medical legal partnership experience, one of the most important partners in making sure that legal services got to patients was a social worker. So having not only a lawyer and the clinical providers on the team, but a social worker who was able to basically connect not only the providers and the professionals with the patient, but also the patient with the community resources, turned out to be key. Our medical legal partnership that I'm telling you about here was also fortunate to have behavioral health specialists on the team. So there were times when we had clients who were fortunate to have a conversation, we were able to have a conversation about their mental health, their physical health, their social conditions, their economic conditions, and all of us, including the lawyer, were able to comprehensively integrate our solutions and help those patients and clients. That's the way we got great outcomes on some issues for baby Eduardo and his family. Bringing mom into status was huge. That meant mom was also not afraid to take baby Eduardo for care. But those kinds of outcomes only happen with truly integrated care. So back to Dayna Hernandez's study. This is a great study because it had a control group. It's also very helpful because the pre-post study showed that 83% of families that had a medical legal partnership had improved housing conditions. Whether that was they didn't experience a utility cutoff in the 12 months prior, or they had stability, were not evicted or moved in the 12 months prior, improved housing conditions from a physical standpoint, leaky plumbing, again, moldy paint, lead paint, and so forth. 83% reported that the medical legal partnership intervention actually improved their housing outcomes. I just want to show that the national data is mirrored in Colorado here. On the left, you see the relationship between education and health. This is the third of those elements, IHELP, education and health. And on the right, you see not self-reported health, but health behaviors. So what are the interventions that a medical legal partnership might make with respect to education? So here, I'm going to tell you what we are doing and what medical legal partnerships ought to do also. Right? So if you follow the green, dark green line, you see that self-reported health obviously improves with education and decreases or is less successful with lower education levels. On the right side, you see that health behaviors are associated with education levels. So we see higher levels of obesity, higher levels of sedentary behavior and smoking, and of course, higher levels of reporting poor or fair self-reported health as education levels decline. This is just to show you that there is an association between education and health in Colorado, just as there is around the country. So what would a medical legal partnership do about that? Well, as I say, we are doing around the country and in Colorado individual education plans for those who are experiencing disabilities, but not getting the kind of guaranteed treatment that their disabilities would, under the law, should be afforded to them. So we're doing a great job with respect to the disabled community, and helping them get access to education. My beef with the medical legal partnership community, right? Even if this was a room of medical legal partnership folks who are already doing the work, is that we're doing a very poor job with respect to the interventions that have to do with educational discrimination. Educational discrimination is a key cause for low educational attainment. There are laws on the books that would help us address, for example, the disparity in discipline procedures by race and ethnicity that show up not only around the country but also in Colorado. So there is more legal work to do with respect to education. So having looked at income equality, having looked at housing, and having looked at education, that's 3 of the iHelp categories. I'm going to move now to talking more about what I think we can do as a group with respect to medical legal partnerships. If you're interested in the rest of the iHelp acronym, we've got a paper posted on the Brookings website. You can look at the data, not only that associates the iHelp acronym to health outcomes, but you also can look at the interventions, the medical legal partnerships interventions, and the outcomes that have been shown so far in the literature at that website. I want to turn now to population level interventions that medical legal partnerships can make. Because medical legal partnerships actually can improve health, not just on an individual level, but also on a population level. I'm going to use first the instance of Flint, Michigan. While I was in D.C., I was on the health policy staff for Senator Debbie Stabenow. She is the Democratic senator from Michigan. I was appointed to her staff in November. You may recall the declaration of a crisis was in January. So I got to be in the eye of the storm. But you also may recall that despite all of the work that was done by Debbie Stabenow and others, very little has actually been delivered, right? We have very little change from a legislative point of view. So that's the timeline. You remember the story. That's what the water looked like. What I want to describe for you are population disparities, population inequities that a medical legal partnership could and should be addressing. So Flint's demography, you remember, not very remarkable from a gender standpoint or an age standpoint, very remarkable from a racial standpoint, very remarkable from an income standpoint, right? You see here that over 56% of Flint's population is African American or Black. You see that over 40% of Flint's population is below the poverty line. We used to see housing discrimination this way. We used to see express, overt signs. We don't want you in our neighborhood. We don't want you near us. Those were the kinds of discriminatory actions that our law was prepared to deal with. Today, housing discrimination in Flint looks much more like this. 47% of the population lives in what we call sick houses, right? This is a picture of a Flint house. Houses that are substandard in their quality and therefore, in fact, are a health risk to the occupants and the residents there. That large a population living in sick housing, like this, is a population health problem that is engendered in part by financing, right? This is a map that shows redlining in Flint, Michigan, that is illegal redlining, that a medical legal partnership intervention could on a population level intervene in to change the financing discrimination that has occurred in Flint and other cities. We also could intervene to address the discrimination that steers low-income participants or low-income occupants to the sick housing neighborhoods in the first place. So this is some data that shows that, for example, if I, as an African-American woman, go to a realtor and say I'm interested in buying a house in Flint or anywhere else, the likelihood is that I will see 17% fewer houses and 11% fewer rental units today, 2017. That kind of illegal behavior is the kind of behavior on a population level because of the association between residential segregation and health outcomes that are poor, that a medical legal partnership could intervene in and address these residential segregation patterns. Now, if you don't know the literature, David Williams and others have written about the association between segregated housing and health outcomes. It's rich, and it describes the association that a medical legal partnership could intervene on a population level. Education. This is what education discrimination used to look like. Today, education level discrimination in Flint looks different. It looks like this. Flint, Michigan has 15 public schools. Of the 15 public schools, 8, over half, 8 of the public schools are either 80% or more African American and Latino. It's almost as if the Brown versus Board of Education decision never happened in Flint, right? We also have very good data that tells us that educational segregation is directly associated with poor health outcomes, because educational attainment will affect income potentiality and employment, will affect housing, will affect health outcomes, as I described earlier. We also know that grading, tracking, we also know that discipline, as I talked about earlier, we know that dropout rates are very closely aligned with income stratification and with racial status as well. This is a discipline pie chart that shows the big blue chart, part of the chart is the number of black boys who are suspended or expelled for 1 day or more in K through 12 nationally, and that's clearly the largest group. A recent study out of Yale University, Yale Child Study group just reported 1 week ago, it may be a little more than a week now, that there is a racial disparity between the amount of time that teachers pay attention to black boys and black girls, looking and expecting discipline problems to arise, and the time that they pay to white children. These are the kinds of the discriminations that affect health outcomes and health attainment that medical legal partnerships can address. Lastly, this is what food insecurity used to look like from a racial and ethnic standpoint. This is a picture from 1963 of a sit-in where people were getting food thrown on them. We know what to do about this kind of overt racism. This is not what happens anymore. Instead, Flint, Michigan, again, last slide on Flint, when we looked at what we could do, one of the most impactful telephone conversations I had with Dr. Mona Atichana was, we need fresh food and vegetables in order to be healthy in Flint. This map shows the fact that, at least as of the day that the emergency was declared, there was not one single supermarket chain in the city of Flint, right? So we could, at a population level, begin to change zoning laws to incentivize Kroger, Safeway, King Super, Piggly Wiggly, whoever wants to go in, and begin to provide food choices for these populations to be healthy. This city was poisoned. This city was poisoned not just by water, but I would submit to you that they were poisoned and are being poisoned, as many other cities in the country are, by a social determinant of health structure that is inequitable and needs a lawyer to intervene. So what could you do? There is really good data. Elizabeth Bradley is probably the leading economist. There is really good data that shows when the ratio of social spending to medical spending in a nation and in a state favors social spending over medical spending, health outcomes improve. So this chart shows a graph from a recent article that Elizabeth Bradley published in Health Affairs. It shows each of the 50 states, and if a state is below the line, its ratio of social spending to health spending is low. They spend more on Medicare and Medicaid than they do on public benefits. If it is above the line to the far right, their ratio is high. So you can see Colorado is not only below the line, but spends about 3% of our state GDP on social spending. that has a health impact as well. Elizabeth Bradley has been very, very prolific in publishing data that shows that the ratio of social to health spending affects at least 7 health outcomes: type 2 diabetes, infant mortality, death from lung cancer, and so forth. So if you want to help, one of the things you can do is work to increase social spending in Colorado. Your vote matters, your advocacy matters, and if I may say, one of the things I did learn in Washington is that when doctors get involved in the policy conversation, things change. Another thing you could do is provide research for population health problems. I'm showing here the I-70 corridor because our medical legal partnership in Colorado and Boulder today is working to support the legal cases that have to do with the I-70 replacement. So if you know about that, I'll shorten my comments. The I-70 replacement, again, not enough people. I'm going to have to tell you more. So the I-70 corridor includes the neighborhoods of Swansea, Elyria, Swansea, and Globesville, right? And way back in 1973, when I-70 was originally constructed, it was obviously placed, I-70, in this neighborhood, which is somewhere between 50, depending on what part of the neighborhood, whether it's Swansea or Elyria, 53 to 68% Latino, and similar numbers with respect to low income. So it's a vulnerable community, the kind of community, again, that medical legal partnerships are concerned with because of their health risk and lack of representation. So in 2016, the Colorado Department of Transportation, after a lengthy process, has approved a replacement project because the infrastructure where I-70 crosses through these 3 neighborhoods is crumbling. The replacement project will triple the width of I-70 in the neighborhood. It will displace approximately 200 households. It will cut through an existing playground at the Swansea Elementary School. The Colorado Department of Transportation has offered and will provide mitigation for these damages. But one of the things that we are doing in the medical legal partnership in the Colorado Health Equity Project is looking at how much mitigation should be provided to this neighborhood. There are 3 lawsuits. One is a Title VI claim alleging that the city and the state have not fairly accounted for the racial impact that this project will have on a minority and vulnerable community. One is a Clean Air Act case. It has to do with health impact requirements not being fairly followed in terms of creating the mitigation solutions. And another one is what's called a NEPA case. In none of these cases do we have enough research to really understand the health impacts. And we need health assessment help, and we aren't the only ones. So the other thing that we desperately need is providers who are willing to do research in support of providing health information for corrective kinds of litigation and negotiated settlements, such as the one that's going on in the I-70 corridor. Lastly, I want to give a shout out to the Farley Center, which is actively working on making state policy, especially in payment reform and financing, that will support the social determinants of health. A third thing that you could do is advocate for and support the kind of legislation that will finance medical legal partnership interventions and other interventions that address the social determinants of health. Colorado could include in its state plan the kind of coverage that can be used for medical legal partnerships and other social interventions. Colorado could submit housing coverage and other alternative services, social supports could be covered when physicians and health providers who understand the impact of social determinants join lawyers in the advocacy work, I know that's a heavy word, in the educational work so that legislatures understand why paying for these types of interventions has health outcomes impact, then we will move the needle on paying for social impact. You can also join a medical legal partnership. I would love to see one back here on the campus. There was one from 2009 to 2013 at Children's Hospital. When it closed, we, Colorado Health Equity Project, picked up a few patients like baby Eduardo that I showed you at the outset. Right now, a private firm is donating its time. I think it's Faber Benson is doing it, over at Children's Hospital. But the need is far greater for a medical legal partnership back on this campus that would address the social needs of especially children, because early interventions make such a difference. You can educate yourself. You can support the partnerships that exist. This is the slide I usually end on because Martin Luther King is famous for that statement about the injustice in healthcare being the most inhumane form of justice of all. But I want to end instead on this slide because it puts me in mind of the fact that only if we work collaboratively. That's Martin Luther King walking with not only a Hindu priest, not only a Jewish rabbi, and a Protestant priest, but because he is working across boundaries, intersectionally, truly integrating the effort for, in this case, justice, we would, I think, take a lesson from him if we worked together on preventative health care. Thank you. I guess I'll be the keeper of the queue. Are there questions? Yes, ma'am.
I was just wondering, going back to the financing side, is any movement as we're looking at private insurers really moving away from fee-for-service to value-based payments that focus on prevention? There's any work amongst private insurers to really start reimbursing for this, or moving forward?
Yeah. So I want to say a little bit about blended financing, private sources of funding, public sources of funding, and defer a little with respect to solely private spending for two reasons. One, I don't know a lot about private spending. But two, one of the reasons I focus on public spending is because Elizabeth Bradley's data and others tells us that public spending is actually what moves the needle from a health outcomes perspective. So when she looks at the ratio of social to medical spending, and within that ratio, the portion that is public versus private, it's the public spending that has the largest bang for the buck with respect to health outcomes. But are there other other insurers and payers who are doing more work with respect to covering social risks and paying for social risks? There are some. HRSA leads the pack right now, right? So HRSA, working with federally qualified health centers, recently released a new rule that allows federally qualified health centers to pay for medical legal partnerships, civil legal services as part of their wraparound care, right? This kind of work will only be done if it's paid for. One of the reasons that the Colorado Children's Hospital medical legal partnership closed was because it was on a purely volunteer basis, right? That's not a sustainable model. We certainly can't scale that up so that every low-income and vulnerable child in Colorado has access to justice as well as health care on a volunteer basis. Can't do it, right? So HRSA leads the pack, if you will. Medicare just released a new in lieu of rule, which might be useful so that partnerships and collaborations that health providers make with, for example, a housing provider or an educational consultant to provide services in lieu of direct health care might also be charged and reimbursed to a Medicare provider. And that's a brand new rule that came out, I would say, less than 3 months ago, right? Another one of the things we would love to see, and I'm not sure we're going to see it in the next 4 years, but if the quality standards include social risks and addressing social risks, then there will be incentive for providers to create their own solutions, to extend their own opportunities to address social risks and encourage for reimbursement. PTAC is a new federal level board that takes physicians' recommendations for new payment structures. I bet if we had the incentive through quality standards that included social risks, then we'd see more physicians making proposals to PTAC to reimburse those because the quality standards couldn't be met without interventions. So we have some macro ideas at this point. We think, frankly, that probably some of the best opportunities will come out of managed care, Medicare Advantage, and the ACO here in Colorado. Probably that flexibility is the best for the best hope for paying and financing medical legal partnerships. Yes, sir.
Thanks for a great talk. What might or how might medical legal partnerships intervene regarding educational attainment? You said that was an area that is sort of uncharted.
Yeah. My personal interest right now is in talking about discrimination, right? Because it has such a detrimental effect on educational attainment. So we have data that tells us that from preschool, age 3, we see really disparate discipline with respect to race, ethnicity, and even skin color. We have really good data that skin color alone will change those discipline structures. So I would love to see medical legal partnerships go in and do some work with respect to enforcing the law with respect to equality and equal protection for kids of color so that they have a shot from preschool to have equal educational attainment. Another area that I would love to see medical legal partnerships do a better job with respect to educational attainment is financing, right? So some of what is going wrong with school and educational financing has expressed itself in educational attainment just because of the wide disparity of financing that translates into resources for underserved and vulnerable populations. So I will have fewer AP courses. I will have fewer extracurricular activities. I'll have the teachers who are least experienced and least likely to stay in the lower income, poorly financed schools. If we could change, from a legal standpoint, the financing structure that disparately directs resources to well-income or high-income populations and equalize them for low-income populations, I think a medical legal partnership could improve educational attainment. Yes, ma'am.
Thank you for an excellent talk. As far as the Flint water crisis, which you mentioned, what could we as individuals, healthcare providers, and communities really do to create a lasting impact on this crisis without, or if it's just sending water, that's like everything. I believe it's probably something.
I wasn't kidding when I said when physicians and other health providers, clinicians get involved, policymakers listen. I cannot emphasize how much of an honor it is to be able to talk to this audience and how much of an opportunity it is. Because when we change the frame that says, oh, that's about water, or oh, that's about housing, that's not what I do, into I have to find a way, if I'm serious about providing quality health care to all, if I'm serious about achieving health outcomes, I have to find a way to make it my business, even though that's not what I went to medical school to do. So in direct answer to your question, from the lowest to the highest level of intervention, one of the things that's lacking is data. Just understanding what the relationship is between these social risks and health outcomes. Understanding what interventions work and don't work, right? Again, if you check that paper out on Brookings, I've got all the evidence there is with respect to medical legal partnerships, and I would still call it emerging, right? So having the ability to depend on, call on, rely upon physicians who want to help create a better evidentiary base is one of the very important steps that we could use if you understand what social risks look like, giving us a hand with respect to data. 2, screening, so that we not only look for biomedical factors and predictors, but so that you begin to identify the social risks that your own patient population is exposed to, and that would need to be fixed in order for a population that's vulnerable to actually get the kinds of interventions that are needed. Why did Flint happen? Because a pediatrician screened, right? Because a pediatrician got it with respect to recognizing elevated blood levels in her population that was at a vulnerable person, that was vulnerable and exposed to a health hazard. The third part is a little more difficult. Dr. Mona had a lot of courage, and she took the information and the patterns that she saw to the authorities. And she said, government, Michigan Department of Environment and Quality, we have a problem. Houston, we have a problem, right? So sharing that information, sharing the data, recognizing the population patterns that you see, and sharing it would be a huge help to the advocates and the policymakers who want to make evidence-based decisions and want to improve population health. If you wanted to walk out of here today and help the kids in Flint, if you wanted to walk out of here today and say, I, as a physician, understand the exposure, if you would simply communicate with your legislators about why they're holding up financing to Flint and ask them to release it, even that would be an intervention. That would be very helpful. Hi.
Thank you. The MLPs have existed for 20 years now in the clinical setting. We've been fighting these battles for a long time in terms of trying to expand, scale, and sustain MLPs that come and go. As we know, the one we started here at Children's could not sustain its own financing to be able to continue. We can get into a lot of details around that, but I'm hearing from these folks that they want to know what they can do today. And I'm just curious to see what from a legal side, when we walk back into the clinic this afternoon and go see patients, short of having a medical legal partnership in place, how do we begin to access legal services? How do we begin to look for them in such a way that we can garner the support to rebuild that need? We know the need exists, but the understanding among docs and in the clinical setting, and then the administration, to help garner that support to say, yeah, we need to put that MLP back in place.
Some of the work is internal, right? It's a great question because what is really necessary is first to identify the need, right? To understand the patient population that you serve lives in a context that is relevant to the healthcare you provide. So if you provide albuterol to a kid and then send them back to a moldy apartment, you're not really going to help their asthma. So doing an internal health assessment of the social risks that your own patient population face would be the place to start, right? So that I would understand what kind of housing does my patient live in, population level. What kind of educational barriers does this population face? What kind of food security barriers does this population face? And make that a part of your individual patient care. Secondly, I think you said it, Shell, you talk about educating yourself to the resources that exist. One of the reasons, empirically, that providers don't ask about housing and education, even when they believe and buy the social risks impact or the social determinants explanation, it's because they don't know what to do with the information once they obtain it. right? So beginning to understand what kind of alliances and partnerships and collaborations there are with existing community resources. When I say medical legal partnership, I don't mean that you, the provider, have to become an expert in educational financing, school financing. I don't mean that you, the provider, have to become an expert in all the affordable housing rules and where Section 8 works and where Section 8 doesn't work. I mean that you have to become savvy about the partnerships and resources that exist and build those relationships and build those bridges so that you can direct and give your patients access to the kind of resources that will address their social needs. Thirdly, I honestly believe that the best model is when the medical legal partnership is in the clinical setting. People will come to their doctor when they don't even know that they need a lawyer. So having the opportunity for us to work together, screening, referring, and resolving the kinds of legal problems that are health problems, right? Seeing legal problems as health problems is a different paradigm. It's a paradigm shift. So beginning to have that resource in-house clinically is really the highest and best way that if you walked out of here today and began to talk about it and made the decision that this was something you would do, would be helpful. The last question, of course, is how to pay for it. How are we going to sustainably finance having a lawyer in-house helping you understand the social needs, helping you understand the laws that exist to address those social needs, and helping connect you to the resources as part of the team so that preventive lawyering really does become part of your message? It's my view that if we had had more support from, oh God, I'm about to say Children's Hospital financially, the medical legal partnership that closed would still be operating today. So part of the financial model that is beginning to work around the country is when providers begin to become financially responsible for addressing the medical legal risks their patients face. I'm invited to leave now. Yes, ma'am.
I'm an epidemiologist in this room. Last week, a lawyer on campus, Don Brush, shared with me his paper, Framing Child Welfare as a Public Health Law Issue. And also he shared with me an idea to test the state statute here. He spent 20 years, make that effective in 2012, to use interrupt time series analysis, to able to evaluate intended and unintended effect of this law. So my question to you is how we, really put this type of project, from ideas and into completion. How the way to build team science here? And I know there is a transdisciplinary approach to public health law, the emerging practice of legal epidemiology, where epidemiologists or epidemiologic methodology be helpful for physicians here, and also the legal practitioner partnership.
So you just gave me chill bumps, right? Legal epidemiology, oh my God. I just died and went to heaven, right? I would love to get together with you after to talk about what kind of translational services there are on this campus. So when I left, is it C? I always get this acronym wrong. CC? TSI, right? Takes science like this and translates it into actual interventions, right? I'm a true believer that whatever works should work first at home, right? And so I would love to see and have a conversation about taking that kind of science and translating it into interventions and changing in practice right here on this campus right here with these practitioners, right? I will tell you that my time in DC told me how important Colorado is to the national health policy conversation. There's lots of reasons for that. Some of that is because Denver Health is here. Some of that is because our exchange worked when other exchanges didn't. Vote to keep it financed. Some of it is just because we have lots of progressive things going on from healthcare. If we here at the University of Colorado Health Center were actually to implement the kind of legal epidemiology data that you're talking about and talk about interventions, the word would get out nationally and we would have an influence. So I think we should start here. Sounds exciting. Can I get, okay.
I am very concerned about the I-70 project that you talked about. And I'm wondering what you think is the best way forward for that impending, looks like, disaster.
The best way forward, in my view, is to make sure that the community that is impacted is both educated and listened to. So my students in the Medical Legal Partnership in the law school are required now to attend the community meetings. It's a very well-organized community. And the reason you hear me being very careful about my words is because as a lawyer, my job is to blow things up, right? I am all about disruption. I came to the problem thinking I want to redirect the highway. I had in one hand the decision from the Corpus Christi, Texas highway project that the Federal Highway Commission had to redirect. And what I really wanted was to move the lanes, shorten or change the configuration. The community is not sure they want that. They may just want, for example, there's an alternative that would lower the highway around the school, move the Swansea school playground, put what they call a lid, a 2-block lid over it, right? And leave them with air conditioners, replaced windows, and some other mitigation factors that will allow them to close their doors, but they're happy to stay there. For me, the disruptive lawyer, that's really hard. That is really hard. But it is very important that people are given the respect to choose their own solutions once they know what their choices are. All right? So I think the path forward from a practitioner or clinician's perspective is for you to know the 3 lawsuits that are pending. In fact, as we speak, the Title VI lawsuit might have a decision today. Right? That was a very exciting complaint for my students to see. Because of the change in administration, I don't care I do care, but I don't want to talk about who you voted for. But in order to get any chance of getting a finding of discrimination, even though the city of Denver and the state of Colorado admitted disparate inequality in the impact, we had to get that decision, that complaint submitted, and hopefully decided before the Obama administration left office. We think that we did it. We think that if there was a chance of finding a discrimination, we're going to find it, right? Then it'll be about negotiating a settlement. And in order to do that, we have to have an analysis of the cumulative health impacts. We are told by EPA that the science doesn't exist. That can't be. It cannot be that it is too hard a question to answer what the cumulative impacts of having been a Superfund site, having a 22-lane highway come through, and having manufacturing on your health population. It can't be that it's impossible to combine those effects. But my year at EPA tells me the science isn't there, right? You guys please get to work because it is hurting the population. So those are some of the things that are important for the path forward. Right now, the Clean Air Act attorney, Rob Youngke, wrote to my 6 students and said, we need a health assessment. I'm like, I can't do a health assessment. But if somebody here can help me figure out how to do a health assessment for a population that we think the standards for the, I'm getting into some of the minutiae, but the record of decision changed the standards for evaluating the health impact and assessing the pre-highway construction impacts. We need help with that, right? So those are the kind of things that could be done. in order to help with the I-70 project. I got a little bit too much in the weeds, I know. Last question? I promise I'll be non-controversial.
This morning in the newspaper, there was an article on undocumented people who couldn't get Medicare, Medicaid for dialysis for end-stage renal disease. And the figure that they cited in their article was that it costs 3.7 times as much to treat this one guy once a week on dialysis as it would if he came in 3 times a week under Medicare or Medicaid. Why doesn't the economic argument alone carry the day in these decisions?
So it's a great question, and in fact, I didn't even touch on how much cost savings there is to having preventive lawyering and preventative healthcare work hand in hand. It's a really important change. I'll answer this way. I had a great time on Capitol. It was exciting. It was great to be there in the eye of the storm, but I learned something really important, and that is that even if you have the exact right policy, the politics can kill it, right? The politics are as important, if not in some instances more important, right? So part of the policy challenge for me, for medical legal partnerships that are advocating for population level and policy level change, is how to frame the kind of savings argument that you're making so that we can build constituencies from otherwise competing or opposing groups, right? So you have to figure out how you can make it a win for enough interest groups to work together with respect to an economically very clearly sensible policy. You can't just say it's going to help vulnerable populations. You lose, right? You can't just say anymore in this climate, you're going to improve health disparities. You lose. You can't say we have to do something about health equity. But you can say that we're going to make the government's price tag smaller, right? You can put language together so that you build enough bridges, enough collaborations. That's why, let's go back to that slide. If you can find enough people to walk together with similar interests, you can make obviously good policy happen despite the politics. So thank you.
I died and what the hell? Dr. Matthew is going to